Thank you for the introduction. I'm in my Hawaiian shirt, which means it is winter clinical, and we are going to be focusing this talk on incorporating prognostic gene expression profiling into the management of skin cancer. As a dermatologist, we have many different decisions that we need to make when we see a patient with a lesion like this on the left, which is an obvious melanoma. We're going to sample this lesion, but we want to make sure that we sample this in a fashion that's going to give us the best prognostic information downstream. And the reason for that is that there are many things that this pathology specimen is going to tell us about who's at risk to ultimately develop what we see on the right here, which is distant metastases. And so as a dermatologist, we have multiple decisions we have to make. We have to decide how we're going to follow these patients, with what frequency, and who's going to get imaging. We have to decide who we're going to send to surgical oncology to have either wide local excision with or without a lymph node dissection or sampling. We have to decide who is going to get referred to medical oncology. There are many good drugs out there now for advanced melanoma, and making the decision up to who goes to get these drugs is the decision of the dermatologist. And ultimately, there may be trials or other types of adjuvant therapies that our patients who are at risk will qualify for. But one thing NCCN tells us as quarterbacks of this decision is that NCCN recognizes that the patient's individual risk of recurrence should drive all of these management decisions. So what are we going to talk about with these management decisions? We're going to talk about how our current system of staging, AJCC staging, doesn't always tell us who's going to be at risk. And so if we look at the circle on the left here, what we see is that if we count our stage 1, stage 2, and stage 3 patients, we're doing quite well as dermatologists diagnosing melanomas, 92% of them in either stage 1 or stage 2. However, a sobering fact is that if we look at the curve on the right here, what we see is that over 60% of the ultimate deaths that come out of melanoma arise from these patients that are initially diagnosed as stage 1 or stage 2 disease. And so because the majority of these patients are dying from thinner disease, we certainly have things within our staging system that could be improved as far as prognostic accuracy. And one of the major emphasis points for today will be that early intervention consistently gives better outcomes when we get these patients to the surgical oncologist and to the medical oncologist sooner rather than later. So we're going to talk about addition of a genetic test. It's the 31 gene expression profile test known as DecisionDx-Melanoma, and how it can add independent prognostic value to these decision-making trees when we are trying to decide who's at risk for either a melanoma recurrence or the possibility of a positive sentinel lymph node biopsy. And so how is this done? Patients with stage 1 to stage 3 melanoma, you can send a sample of the melanoma biopsy specimen off to a laboratory in Phoenix. That's done directly from your dermatopathology lab. An area of the tumor is macro dissected out from the surrounding tissue, and ultimately 31 genes are simultaneously amplified. And the expression of these genes is known to correlate with either a more favorable outcome, which is what's called a class 1 gene expression profile signature, or correlated with a poor outcome, which is class 2 signature. Class 1 and class 2 are further broken down into 1A. And what 1A is if all of the discriminant genes of the 31 genes that are amplified are pointing in a favorable direction, you'll get an outcome that looks, that's going to be called 1A. When things are really all pointing in a concerning fashion, you will get an outcome that is 2B. And then there are two intermediate risk groups. 1B is one where most of the genes are pointing in a favorable direction, but there's maybe some indeterminate calls. And 2A is a concerning, it's a high risk gene expression profile, but not quite as high as the highest, which is 2B. But ultimately, when you do these tests, 74% are going to come out as 1A, 11% as 2B. And so most of them are going to come out either very telling towards the low risk or high risk end, with 15% making up the intermediate risk group. And so what are these risks? Well, one is for melanoma recurrence risk, and we will talk about that. As well, we're going to talk about the risk of sentinel lymph node biopsy positivity, which can be better directed using gene expression profiling. So gene expression profiling using the DecisionDx melanoma test is now very widespread in use in dermatology. Over 5,700 patients have been involved in studies yielding over 25 publications. And if you look at the clinicians, people like you and me that are ordering this, it's over 58,000 patients that have had DecisionDx ordered by almost 7,000 of us dermatologists. This has now been approved by Medicare and it's being paid for both the indication for sentinel lymph node biopsy guidance as well as recurrence risk. And Medicare acted upon this based upon the ability of this test to alter decision-making patterns by dermatologists. And then meta-analyses have recently shown that this gets a 1A level of evidence, which is supported by high-quality evidence at a high-level recommendation when using sort criteria. So this is the 2,600 patients that have been involved in recurrence risk, looking at both archival specimens as well as prospective studies. If you look here at the top left, what you see is Dr. Padram Garami's initial 2 papers, which defined this test and showed its utility in thin melanomas as well as in thicker melanomas. Jonathan Zager's multi-center cohort also is shown here. And then I think if I'm referring people to learn about gene expression profiling for the first time, this paper by Dr. Brian Gassman from Cleveland Clinic and others in the January issue of JAD from 2019 shows a 690 patient summary, and this is showing the recurrence-free risk, recurrence risk for patients with a 1A signature, which is on top here, those patients doing quite well, versus 2B, and then you see your intermediate risk groups in the middle. We're going to come back and look at this data set in a little more detail. In addition, there are now prospective data sets, not quite 5-year and beyond rates of recurrence or survival like the archival specimens have, but in studies that go out for an average of about 3 years, what you see is remarkable consistency across the board between different studies, showing that class 1 patients always have a much better outcome, statistically significant, than the class 2 patients. So now we're going back to the Gassman 690 patients, and when you look at the melanoma specific survival of these 690 patients broken down by stage, what you see on the left here is that those patients had in stage 1 a 98% melanoma specific survival, which is above this red line here, which represents the NCCN low risk category. That's typically where our stage 1 and 2A patients lie. Our stage 2 patients, all comers in the 690 cohort, showed a 90% melanoma specific survival, and stage 3 did worse at 77%. Well, can you better stratify patients here using gene expression profiling plus AJCC staging to better identify subsets of patients that are either going to do better or worse? We already showed in those previous circle figures that there are certainly patients with thin melanomas that will go on to have bad outcomes. Well, so let's take the worst case scenario first. So if you look at gene expression profiling and you look at the patients in each of these stages that have a class 2B genetic signature, and you look at the stage 1 patients, their gene expression profiling is concerning, and their melanoma specific survival echoes that. It is down to 89.5%, and that has actually crossed the threshold from what NCCN tells us is low risk to a mortality that is essentially high risk. And so these patients, despite the fact that they are stage 1, have a mortality rate that looks like patients who have stage 3A melanoma. And if you take nothing away from this educational session, it's that these patients deserve to be managed more aggressively. We should be managing them the way that we handle our stage 3 patients. Stage 2 patients, there was a 90% melanoma specific survival. If you take the class 2Bs of that group, they do worse. They fare the way that stage 3B patients would be. And then our stage 3 patients with another bad indicator do quite poorly. What about if I tell you that you need to do more for these patients on the left here? Or is there a group of patients that you could potentially do less for? Well, indeed, you can find out of these groups which patients have a better outcome. And so these are the patients, stage 1, stage 2, and stage 3, that have a gene expression profile class 1A. So can you get better than 98% melanoma-specific survival? Indeed, you can. Class 1A patients with a stage 1 diagnosis have a melanoma-specific survival that's 99.6%. And that is a figure that I really like. I think that is such a high negative predictive value that many times we're looking for points of optimism with our patients with melanoma. And this is something that I rely on time and time again as a reassurance measure for patients that we are going to manage, usually with a dermatology-only approach without the need for our oncology colleagues. Interestingly, if you look at our stage 2 patients who have a gene expression profile class 1A, their melanoma-specific survival goes up almost as high, to greater than 99%. And so these are patients that you could consider doing less for, once again, employing an approach that only uses a dermatology-centered treatment plan for these patients. Interestingly, and more of a discussion for our medical oncology colleagues, we do know that there are subsets of stage 3 patients that do quite well. Who are they? Well, it's the class 1A patients. Their melanoma-specific survival also crosses the line from high risk all the way up to low risk. Their melanoma-specific survival is 94.8%, and that is consistent with what a stage 2A patient has, which is what NCCN classifies as low risk. And so this is one of my favorite slides in the entire deck, but tells me that we certainly need to do more for some patients that cross the line from low risk to high risk, as well as a very high negative predictive value for these stage 1, stage 2, and even stage 3 patients with a class 1 gene expression profile. So now if I want to look at a subset of those last patients, let's talk about the thinnest tumors in general. So we're going to talk about T1 tumors that are less than 1 millimeter in depth. And if we look at the number of patients with those tumors, there was about 300 of them in the study. And if we look at recurrence-free survival here, what we see is a cluster of GEP1As, 1Bs and 2As that are all up top here. And then definitely this gene expression profile identifies a class of patients who are indeed at very high risk of a recurrence. And that's your 2B patients. I also like to look at this curve just because the steepness of the curve seems to fall off quite rapidly here in the first 3 years. And after that, it levels out. So if I tell you that we need to do more for this particular subset of patients, I think what it involves is imaging in particular in the first 3 years. If you look at some of the variables that predict who's going to have a recurrence in a multivariate analysis, and you compare our classical predictors of risk, what you find is the gene expression profile has the hazard ratio, the highest hazard ratio by far, and is really the only thing that stacks up to be statistically significant in identifying which one of these patients is indeed at risk for a recurrence. So I tell you this works very well to identify a certain subset of patients that go on to have events such as recurrence or distant metastases in thin tumors. Should we be using this on all of our thin tumors? Well, so this is a very interesting study. The first author is Dr. Marks and the senior author is Clay Cockrell, but this shows recurrence risk for thin melanomas up to 1 millimeter in thickness. And if you look at gene expression profiling, this is for 669 patients, and you look at the ones that come back with the low risk signature 1A, what you find is these patients do slightly better on average than all comers. What is much more interesting to me is the 2B patients with thin melanomas. And so we already talked about that they're at significant risk for recurrence. And what you see here is an inflection point about 0.3 millimeters in depth, where beyond that, there's a very sharp increase in the amount of recurrence that you see in these thin tumors. Interestingly, also, the authors of this study looked very carefully in this less than 0.3 millimeter depth population. And what they found was actually no events, essentially no distant metastases, no recurrences. And so what this tells me has actually been something that has changed my practice. If you start to look at tumors, say your 0.1 and 0.2 millimeter depth melanomas, and you're ordering DecisionDx here, you'll have to order an awful lot of those assays before you find a result that's going to change the way that you practice. And so since being aware about this paper, I have stopped ordering on my 0.1s and 0.2 millimeter depth melanomas, really reserve this for 0.3 millimeters and up, which is where our literature tells us we have the highest uptick in terms of recurrence. Once again, you can see a recurrence-free survival in the class 2Bs in our 0.3 to 1 millimeter thickness that's as high as 25% recurrence rate. Once again, your class 1A is a very low recurrence rate. I did mention before two recently published meta-analyses. So these are two papers that actually looked at the body of available evidence and were able to analyze it and in summary find that this assay has sufficient evidence to be included as something that they would recommend for use in addition, not to replace AJCC staging, but in addition to AJCC staging to predict recurrence risk in patients with melanoma. So in summary, if we're talking about our melanoma recurrence risk, what we talked about was that there are certainly thin tumors that go on to cause disease in terms of distant metastases and death, and that staging only will miss certain tumors that go on to have aggressive biology. Gene expression profiling using DecisionDx-Melanoma can be used as an addition to standard AJCC staging to better identify which patients are going to be at risk for distant metastases or recurrence. Using these two together gives you a better stratification of individual recurrence risk, and we didn't talk about this too much today, but essentially you would want to increase the amount of imaging that is done for at-risk patients because imaging actually proves time and time again to be the method by which most distant metastases are identified. And when we identify these distant metastases earlier, typically this is associated with better outcomes in the oncology world. So now I'd like to talk about the second indication for DecisionDx-Melanoma is to inform sentinel lymph node biopsy guidance. And I believe that many dermatologists are aware of our cutoffs for when we refer patients for sentinel lymph node biopsy based upon depth. But the guidelines for sentinel lymph node biopsy actually go beyond depth, and they're really based upon the positive predictive value of the test. And so if your positive sentinel lymph node biopsy positivity rate is less than 5%, which it is with our T1A tumors, essentially this is a group where we do not recommend sentinel lymph node biopsy based upon NCCN guidance. When the sentinel lymph node biopsy positivity rate is between 5 and 10%, that's something where it should be considered, and greater than 10% is usually something that gets a pretty strong recommendation for sentinel lymph node biopsy. So how are these made? Well, we know certainly from MSLT1 that there is a false negative rate of about 5. And even using this 5% threshold, what we do find is that overall the number of positive tests that are done actually only ends up being about 12%, which means that 88% of the patients that ultimately get sentinel lymph node biopsy really don't get much benefit other than a negative result. And so why should we consider improving this? Well, I think this is all about getting the right patient, the right treatment at the right time. We talked about the fact that many patients may derive no benefit. And MSLT also identified that really there is no survival benefit to this procedure. It is simply prognostic. However, for being one of our better prognostic assays, it often fails us. As a matter of fact, 2 out of 3 times sentinel lymph node biopsy negative patients end up with distant metastases compared to patients that are sentinel lymph node biopsy positive. So only 1 out of 3 times does the sentinel lymph node biopsy tool correctly identify patients that go on to have distant metastases. And so really getting a better focus on who can benefit from this procedure was something that Castle sought to do. And doing this, they managed to enroll approximately 3,000 patients into studies looking at T1 and T2 thickness tumors, so sentinel lymph node biopsy eligible T1 tumors and T2 tumors up to a depth of 2 millimeters. And so what did they find? Well, interestingly, the results break down by age, but if you look at T1 and T2 tumors and you look at class 1A gene expression profile, what you find is that once you get beyond 55 years of age, you identify a subset of patients. So in this case, the 55 to 64-year-old patients have a 4.8% sentinel lymph node biopsy positivity rate. Beneath that of what you find the 5% cutoff for when this is recommended. And even more interesting to me is the 65-year-old threshold. You fall below 2% for patients that are class 1A when looking up to 2 millimeters in depth for sentinel lymph node biopsy positivity. So if you potentially could exclude these patients from sentinel lymph node biopsy, are there ones that you would definitely want to include? Well, really that's all your T1 and T2 patients who have anything other than a class 1A. And so the intermediate risk as well as the 2B, the highest risk, essentially those go up beyond the sentinel lymph node biopsy cutoff recommendation of 10%, where you would really want to strongly consider this particular assay. And so looking at the flow sheet again for this particular analysis, we identified that sentinel lymph node biopsy has no survival benefit, but is a prognostic assay. However, for being one of our better prognostic assays, we do know that many patients with sentinel lymph node biopsy status that is negative will go on to have distant metastases. And so enriching this is what this particular assay is about. And if we can use sentinel lymph node biopsies combined with gene expression profiling, what you can find is that patients with a T1 or T2 thickness melanoma who have a class 1A, essentially, if they're above 55 years of age, could be excluded from getting the sentinel lymph node biopsy and still have favorable outcomes similar to those patients that we have excluded without using this particular gene expression profiling. And because this is prognostic only, if you can exclude patients from getting this assay and they still have good outcomes, you essentially get a positive net health benefit of avoiding unnecessary surgery as well as imaging in some of these patients. So we have two flow sheets to kind of look at here. So if we're looking at gene expression profiling and how it can aid sentinel lymph node biopsy, essentially T1, T2 thickness melanomas, when you get a class 1A signature greater than 55, essentially sentinel lymph node biopsy could be excluded and those patients could be managed low intensity in the dermatology office. Intermediate or high-risk melanomas from a gene expression profile for all ages should be referred to and considered for sentinel lymph node biopsy because these patients will have a greater than 10% sentinel lymph node biopsy positivity rate. How about recurrence risk? Well, if you use this as the lead-in for determining whether or not to get sentinel lymph node biopsy status and you have someone that comes back sentinel lymph node biopsy positive, for patients that are class 1, the medical oncologist as well as the dermatologist may consider decreased intensity. For sentinel lymph node biopsy patients that are class 2, those are patients that you want to put on high intensity. In most cases, that's going to involve imaging at least every 6 months for the first couple of years. And for certainly the highest risk patients, you may want to consider trials or adjuvant therapy. Your sentinel lymph node biopsy negative patients or ones that were excluded from sentinel lymph node biopsy based upon the gene expression profile, when they are class 1A or class 1B, those would be ones that could be followed by dermatology only. And the thinner melanomas that do come back with gene expression profiling that is concerning, those would be patients that you would want to upstage their management. So this is a paper by Dr. Quatra and others. This is going to be talked about later on in an industry session hosted by Dr. Aaron Farberg. But basically, this was a consensus paper among several dermatology experts looking at clinical workflow and integrating gene expression profiling into treatment guidelines, and something that I would encourage people to tune in to Dr. Farberg's presentation later in this meeting. So now in the last few minutes, I want to discuss gene expression profiling in cutaneous squamous cell carcinoma. So this is a new assay that Castle has recently launched in the past couple of months. And if we look at disease-related mortality, we just discussed melanoma, but the sheer number of cases of squamous cell carcinoma ultimately with a lower mortality ends up causing more numbers of deaths per year. And so I think traditionally our staging system for cutaneous squamous cell carcinoma has been somewhat of a letdown. I think the staging systems, both AJCC and Brigham and Women's, suffer somewhat from a lack of a positive predictive value or a less robust positive predictive value than we would like. And so can use the same technology that was used for gene expression profiling in melanoma. Well, indeed you can. You can use this for cutaneous squamous cell carcinoma, and indeed Castle has developed this assay. And so this assay, DecisionDx squamous cell carcinoma, is intended for use in patients with at least one high risk factor for their squamous cell carcinomas. These are listed here, and traditionally they're typically thought of as being larger tumors or one with thicker types of invasion. Rapidly growing in patients with immunosuppression can make the high risk list along with patients with tumors in specific areas, the H and N areas. Tumors arising in prior radiation therapy sites, and anything that involves neurological symptoms or large perineural involvement is going to be something, along with histology of poorly differentiated tumors, that makes you a high risk tumor. So can you use DecisionDx squamous cell carcinoma to help better make prognostic decisions about these patients? Indeed you can. So if you send the tumor off the exact same way, it's going to be macro dissected out from initial biopsy specimens. This time there's 40 genes that are simultaneously amplified, and the outcomes this time are 3. Class 1 represents the lowest biological risk, typically half of what you're going to see in the next highest risk group, which is Class 2A. That's our moderate biological risk, and this score is very similar to what you get if you do have some of these previous, one or two of these previous features that are typically associated with high risk we talked about on the previous slide. What you don't want to see is patients that come back as Class 2B, because these patients are actually at quite high risk, greater than 50% risk of developing metastases, and these metastases occur quite early. So here's the Kaplan-Meier plot showing the metastatic free survival here on the y-axis and years on the x-axis. And what you find is that Class 2A is this blue line in the middle. For all comers in this particular analysis, the distant metastasis rate was about 15%. And this is similar to strongest traditional factors for staging. Class 1 patients have a lower biological risk, and so these patients have a less than 10% risk of distant metastasis. However, these 2B patients are ones that you really need to be concerned by. And once you see this line, it's very steep. Here's 1 year where already 50% of these patients have undergone a metastasis. So this, fortunately, represents only about 5 to 10% of patients. Fortunately, about half of patients come back with a score of Class 1, and then about 40% with a score of Class 2A. So DecisionDx is indicated for patients with one or more of the risk factors that we talked about. It does a lot of computational biology to give you these figures, which show an overall risk of metastasis 6.6% in the Class 1s, 20%, 15 to 20% in the Class 2As, and the 2Bs have a very high biological risk of 52.2% metastatic rate. So how does this compare to other traditional predictors? If you look in a multivariate analysis and you look at things like perineural invasion, you start to see the risk tick up a little bit. Deep invasion starts to get to where you are significant with a p-value less than 0.001. Poor differentiation is also shown on here. Class 2A shows up to be a very similar independent risk factor in terms of hazard ratio to what deep invasion or poor differentiation shows you. But Class 2B is the one with the absolute highest hazard ratio and certainly holds its own statistically. And if you look at a Class 2B, a squamous cell carcinoma with deep invasion is 2.1% more likely to metastasize without, But when you add a Class 2B result, essentially you shift that to be about 15 times more likely to metastasize. And so how can you look at this in terms of a flow sheet? Well, if you look at squamous cell carcinoma patients with one or more risk factors and you add GEP in, you stratify them into low, moderate, or high intensity follow-up. For patients with low intensity, these are patients you'll have do surgery on and schedule in your office for clinical nodal exam. For patients with moderate intensity, these would be ones that you do surgery on and consider further imaging as well as oncology referral. And then those high intensity patients are one that really need all of your oncology colleagues getting involved. How is the follow-up to be tailored for these patients? Well, so the low intensity essentially is going to involve clinical nodal exam and follow-up in the office of the dermatologist once or twice per year. Once you get to the moderate intensity follow-up, that's going to be more frequently in your office with additional imaging that's ordered, and then bring out all the stops, in particular for that first couple of years following this diagnosis, where you really want to be imaging these patients quite frequently and getting the opinions of your medical oncologist and your radiation oncologist. So I'd like to thank you for your attention for this tour of cutaneous squamous cell carcinoma and melanoma gene expression profile, integrating it into your clinical practice.